patients who use marijuana, and that could be recreationally or for medical purposes. So, you can't hear me?
I can't hear you.
All right, how about now?
Yes.
All right, cool. All right, so we're talking about the kind of briefly introducing the endocannabinoid system, and then discussing kind of the differences between medical and recreational marijuana use, and then what you guys are all interested in is reviewing the pharmacokinetics, which could lead to potential drug-drug interactions with marijuana. So just briefly, the endocannabinoid system was only discovered fairly recently. There's two receptors. There's CB1 and CB2. CB1 is mostly in the central nervous system, and a little bit in the periphery, and then CB2 is sprinkled throughout immune cells splitting the GI system. There isn't great data as far as like where they're super concentrated, and so most of those studies are from animal studies. But the two endocannabinoids are anandamide and 2-AG. So the way the system works is it's a feedback. So it works to maintain homeostasis. So in the first picture on the left, it's just in homeostasis. And then the presynaptic cell, or the postsynaptic, if that becomes overstimulated, it'll send signals back to the presynaptic cell to send signals back. And so it's a retrograde system to then dampen the postsynaptic cell. And these are in responses to pain, inflammation, any threats to the immune system, and then sorts of stress, such as mood, appetite, or sleep. There's phytocannabinoids. And the main plant is Cannabis sativa. The only difference between hemp, which is recently legalized with the 2018 Farm Bill, is the amount of THC. Normally you'll hear patients talk about indica or sativa or hybrids, and that's sort of an old system because at this point everything is a hybrid. So it's not really used anymore, and what people really refer to are chemovars. So type 1 is mostly THC, type 2 would be a mix, and type 3 is mainly CBD. And if you're part of the DEA, you have a numerous amount of other names for it, with devil's lettuce being my favorite. Okay, so then the two main phytocannabinoids that we are usually focused on are THC and CBD. And then another thing to consider if people are using marijuana, and it's not necessarily for medical purposes, but terpenes are another kind of growing area of research because they sort of carry their own characteristics as far as like what effects they have on the body. So THC, as you may know, it's a major psychoactive constituent. It's a weak agonist at both of the receptors within the system, and it's what's going to get you high. People use it for a variety of reasons. So for pain, appetite, nausea, digestion, emotions, and PTSD. You do want to be cautious in patients with cardiovascular conditions because it can cause vasodilation and reflex tachycardia. And so I'll kind of talk about why that's important, or the significance of that later when we talk about the distribution absorption. And people who have a history of depression or anxiety or schizophrenia, it's usually advised against. And there are two synthetic cannabinoids. Dronabinol and nabilone are both synthetic versions of THC. So it's interesting that we have synthetic versions of THC, and yet the actual form of THC is a Schedule 1, and these are Schedule 2. So again, they have their own pharmaceutical uses. And then CBD is what a lot of, yes?
Sorry, on the last slide, what's the rationale behind the history of depression, anxiety, being a caution against the use of THC, given that it's one of the main reason of uses?
Yeah, it's a weird thing. Yeah, so the question was, if it can be used for anxiety, why is there a caution with using it in people with anxiety? So it's sort of a debate even within the medical and the science community. So THC, if it's just a pure product, that can cause anxiety. But if it's mixed with like CBD or some of the other, like the terpenes, I think it's less of that effect. So maybe it's not necessarily the THC. And again, we don't really know, and there's not a lot of great studies. In Washington, we didn't approve it for that reason, so it's not on the list of conditions that we allow it. But yeah, so it's a great question. I don't think we necessarily know. And it's mostly associated with like anxiety associated with symptoms for conditions. So yeah. And it's thought that like it can cause psychosis or schizophrenia, but it's debatable if it's people are just who are predisposed to those conditions are then it's going to precipitate those conditions. Okay, so CBD doesn't necessarily work within the endocannabinoid system. It's thought to work on TRPV1 receptors and as a 5-HT1A agonist. And this is just our rat model. Again, that can be used for anti-anxiety. It's thought to be neuroprotective. We know it can be used as an anticonvulsant with the approval of Epidiolex. And the other ones are kind of definitely anti-inflammatory, but as far as like anti-tumoral, I think they're still to be discovered. As long as there is less than 0.3% of THC mixed with CBD, then it's a Schedule 5. Otherwise, it's still a Schedule 1, even though the World Health Organization says it's a safe compound. And there aren't risks for abuse or anything like that. And we know we have medical uses for it. And then the other thing that doesn't necessarily get talked about a lot are terpenes. And these are just chemicals that provide scent or aroma to the plant. So the popular strand, Pineapple Express, has citrusy notes, and those are terpenes that are causing kind of that scent or aroma. Some of them are known for their pharmacological properties. And so the ones that are listed are all of the terpenes that are associated with decrease in pain and inflammation. But they're very low toxicity and they're safe and well tolerated. So there's this thought that I think in medicine we want to drill it down to like one compound that is causing the effect. And with marijuana, a lot of the thought is that it's an entourage effect. So it's really a mix of terpenes, CBD, THC, and all the other hundreds of compounds that are in THC that sort of provide the effect that patients experience. So we'll just breeze through medical versus recreational cannabis. In general, it's sort of how you would expect it to be. It's for personal use without medical justification. Normally it has higher THC content and very low CBD content. Medically, it's used, if you're going to, you need to have an indicated state-recognized medical condition. You're going to have a mixed content. And since it is a Schedule 1, there are no prescriptions for it. You only get an authorization through your medical provider. And so it's not a legal binding thing that can help you. And then it's never going to be a first-line treatment. So these are all people who have conditions that are resistant to standards of treatment. The age limits in Washington is 21. Most places are going to have purchase limits. You can't buy it or sell it except for in a state-recognized facility. And you can't grow it. There is no public use, and you can't travel across state lines because it's illegal federally. And as far as driving, in Washington state, it's just a per se limit. So basically, we've just set a limit of 5 nanograms per milliliter. And if you test above that, then that's illegal. Even though those blood levels and the physiological effects that you're seeing don't necessarily correlate. So if people are being charged, a lot of times it's based on the decisions of police officers. In Washington state, these are the people who can provide it. Again, they're offered state immunity, but not federal immunity. And they must have a documented relationship with the patient. So you can't open up a practice where you're going to authorize medical marijuana. I'm from Ohio, and so in Ohio, there are physicians who just have clinics who can offer it, and they can charge fees for it. So it's not I think Washington has a better model, but again, it's not a perfect system. And you're going to monitor it just as you would any other medication. So you have to follow up with them, and you have to do the standards of care of practice. And again, you're not prescribing it because it's illegal to prescribe. You can only authorize saying that this person has a medical need for this. We do offer continuing education. It's not required, though. Okay, so once you authorize somebody to get it, they can take this card, or they can take this form to a marijuana shop, and they become a card holder or not. And really that just what the card holder does is it puts you in the system, and it gives them different advantages compared to a non-card holder patient. So a non-card holder patient, they have the same purchase limits as a recreational user. They can't purchase high THC products. They can purchase, there's no sales, they do have sales tax. They only have an affirmative defense, so if they're caught with more than their legal limit, it's not like a home run, you're protected. And then you can't participate in a cooperative, which basically means you can't, so if you're authorized, say you live in an apartment and you can't grow the marijuana plant because of your lease agreements, then you could join with somebody who has a home, and then together, if that other person also has a condition, you can grow together with him. So that homeowner could have like 30 plants compared to say like the 15 that you could just have on your own. So the card holder offers you other things, and it's basically extended of those. So I don't necessarily have to go through that. And then these are the limits, and basically it's just, if you're a card holder, you can have 3 times as much as a non-card holder, and you can grow plants. And as far as like standards of products, we like to know what patients are taking. And so Washington has a product compliance unit, and it's just more stringent testing on as far as like consistency within products. Okay, and then as far as what people use marijuana for, this is just for CBD, but I would imagine whole plant cannabis would be similar. And a lot of what people are looking for is relief from pain. And so, but like PTSD, nausea, and cancer pain are also included. Okay, and so this is kind of the meat. So we're just going to look at pharmacokinetics and a little bit of pharmacodynamics. So what your body is doing to the drug. So when it comes to absorption, it's going to depend on the product's composition. So you can get a marijuana cigarette that has 8%, or you can get one that has 22%. So you're going to be getting a lot more THC if you have a high THC content product. And then dosing is also important. So a lot of edibles, you get a cookie. I don't know if there were cookies at lunch, or as far as like how many people just ate half of a cookie or the whole cookie. So a lot of times edible products will have multiple servings. And so that's really an area of concern when it comes to children and naive users, because a lot of times it's not thought of. And so they'll eat a cookie that has 60 milligrams of THC, which is quite a bit for somebody who's never had any. So that causes problems as far as cardiovascularly or with anxiety. And then the route of consumption, as you can imagine, if you inhale marijuana, it's going to be absorbed much quicker than if you ingest it through an edible. And so the onset of action is much quicker. It's only between 3 and 10 minutes, but you're going to lose the effects of it much sooner. And so delta-9 THC is the THC that we normally talk about. That's metabolized into hydroxy THC. That is just as active as THC. And then the non-active ingredient is carboxy-THC. So you can see within 3 hours, you're quite much below that theoretical like 5, that level of 5 nanograms where people would say that you can't drive. Whereas with oral ingestion, it's going to take a lot longer to absorb. And it's because you have to go through through the hepatic system. And you're going to have lower peak concentrations and lower onsets of action. So if you look at the bottom graph, you get just barely to 10, and that's within 6 hours. And then it's not until 24 hours where you're getting to lower concentrations. And then your inactive THC form stays pretty high for a while, and which would be concerning if some test, like some driving test or some drug test, was going to be measuring this level of THC, would say that you had been using, but not that you were currently under the influence of it. And then as far as topical absorption, it's not going to get absorbed into the bloodstream. Okay. So when it comes to distribution, if this is for smoking, so you're going to have rapid absorption into the blood, and then it's going to rapidly distribute into the tissues. So highly vascularized areas and then super fatty areas are where it's going to distribute. And so it may be affected by the body size of the person, their compositions, and then any disease states. Chronically, it can become an issue, so it's going to distribute and settle into the fat tissues, and it may redistribute with weight loss. But what's not super clear is sort of how that affects you on a day-to-day basis. Because with chronic users, the effects, like the effects of feeling high and dizzy, those can dissipate with chronic use because you get used to those, but like the pain relieving effects don't necessarily disappear. So you may become intolerant, or you become tolerant to like the nausea, but not necessarily like the ability to relieve pain. So you're going to be increasing if you're trying to get high, but not if you're using it for pain relief. You don't really see people increasing their usage. Okay. So metabolism and elimination. So we just looked at THC and CBD. They're both hepatically metabolized. THC is mainly through 2C9, 2C19, and minor 3A4. And then, like I said, it produces an active metabolite. So the 3A4 system is how about 60% of drugs are metabolized. So big ones would, so like in 2C9 is like warfarin, and 2C19 would be like clopidogrel or omeprazole. But even though these are like major enzyme systems, you're not necessarily seeing results. So if you look, so CBD is 2C19 minor metabolic pathway and 3A4 minor, but a moderate 2C19 inhibitor. And so if you look over in this chart, the amount that you would have to consume, or the amount that they think you would have to consume to see inhibitory effects, are much larger than just normal daily doses. And so even though these are major metabolic systems, the reported drug-drug interactions have really been quite minor. And so opioids are commonly used. So 3A4, you have oxycodone, methadone, tramadol, fentanyl. These are metabolic pathways, but again, there haven't been, when it comes to opioids, there haven't been an increase of deaths from concurrent marijuana and opioid usage. And so part of that is thought because we're prescribing less opioids. Part of it is because it's not just, it's not causing respiratory depression, but it's not increasing the amount of those active compounds. Okay, so when CBD was approved, the only significant drug interaction they noted was with clobazam, and that's because THC and CBD are working on multiple pathways, and so clobazam is an active chemical, and then it gets metabolized to another active chemical, and so you're keeping both of, and then to become inactive, it has to go through this pathway. So you're stopping the pathway that is allowing it to become inactive. And so you're just keeping more of it around. And the main side effect that happened was just increased like fatigue or dizziness and sedation. And so that one was found to have a significant interaction with CBD, but that was really the only one. A lot of them are just kind of proposed and theoretical, and if you have drugs that are narrow therapeutic indexes, it's advised to just monitor those closely, just as you would with any other kind of potential drug-drug interaction. And so patients with migraines, headaches, and arthritis and chronic pain found that they were substituting marijuana. They were substituting those products for marijuana in about those percentages. And so when it comes to like potential pharmacodynamic interactions, the FDA approved, so dronabinol, and the other ones were, those have side effects of nausea and dizziness. And so it may potentiate that. And then I was talking about cardiovascular effects. THC is known to cause peripheral vasodilation, and that can lead to a reflex tachycardia. So if patients have cardiovascular diseases, you may see some pharmacodynamic effects from that. And then we talked about briefly how it can precipitate anxiety or schizophrenic conditions. Okay, so the last thing I'll cover, I ran a little quickly, but there is a condition called cannabinoid hyperemesis syndrome, and it's thought to be a withdrawal effect from cannabis. And so what happens is people find that they're vomiting and super nauseated, and the only thing that can relieve it is hot showers. And so a lot of times they'll report to the emergency departments just complaining of this, and the only thing that relieves it is to take a hot shower. And I did find a study where CBD has a biphasic effect, so at a certain level it can reduce nausea, but at a higher level it can actually precipitate it. And the current treatment and management strategies are to stop smoking or stop using hot baths or showering, and it's thought that because it's depositing in the fat that I take it back. So the TRPV1 receptor is what pepper binds to, and so if you can get it off the receptor, then you can relieve the syndrome. So capsaicin binds to that receptor, and it's a heat receptor, so hot baths and showering would also work. And basically you're just trying to offer supportive care. If they're going to be vomiting, then you just need to make sure that they keep their fluids up. So I guess just like final considerations is that laws and perceptions are changing, and it's no longer what we thought it was. So I think people are going to keep using it, and if anything, that use is going to increase. Laws are changing around. There's a Senate bill now looking to make it legal. The World Health Organization is looking to deschedule it. And I think with that there are going to be more clinical studies. I think it's a big tick against us that we don't have good clinical studies, and that's totally fair to be resistant and to wanting to authorize it or wanting to approve use. But I guess the third point is that it's not innocuous, and it's not innocuous. When it was criminalized, a lot of it was because it was turning people psychotic, and it was like turning people into like pillaging towns. And we're not there anymore. And those stereotypes were perpetrated by people in power. And so I think we've come to this point where we've thought of it being so dangerous, and now it's almost like we've cried wolf too many times. And so a lot of patients don't necessarily think that it's dangerous at all. And so I think we have to offer our opinions and not knock it, but also be aware of what can happen with it. Because so many people are using it. And in fact, I'm working at a geriatric rotation right now, and that population, they have the sharpest increase in use of medical marijuana. And part of it's because they grew up using it, and so they're not necessarily afraid of it anymore. And now that the legal barriers are getting knocked down, I think they're becoming more comfortable using it. And then to be proactive, and so to make sure you're asking patients if they're using it, and if they're going to be on a narrow therapeutic drug, then just to monitor it. That ran quick, but I'm happy to answer any questions if there are any. Yeah.
So my dad is getting a little bit older these days, and when he came out here for a skiing trip, actually we were in Denver. His knee was really bothering. He actually just ended up getting his total knee done. But in the meantime, I did go to a dispensary and get him some CBD oil for his knee. He claimed that it didn't do much for him, but he continued to use the jar until it ran out. So explain that. But I was just wondering we didn't talk too much about the topicals, but what is known about whether or not it is effective, either anecdotally or in studies?
So I think it's there for both. So I just had a patient come in. Her mom had arthritic knee pain, and she said that was the one thing that she gave her, and she found that it helped. And so the tricky thing that came about it was she was staying at an adult family home, and the adult family home would only provide her medications that were ordered by the physician. And I don't actually know how it panned out, because the physician through that facility, they can't authorize its use, but it had to be noted that she was taking it. But so anyways, I guess the point is for her that it worked. And I think a lot of people find benefit in it. It may just be that product. It may be, I don't think it's not like a first line. And so it's hard to say it's going to work for everyone, because nothing's going to necessarily work for everyone. But as far as its use and its safety, I feel like it's safe. So.
What is its indication in head injury and PTSD?
Yeah, so it's funny you asked that. So this picture was taken from a research scientist who wanted to study cannabis use in patients with PTSD. And this was a sample of government marijuana that they sent her. And and this is what is commercially available. And so the other part is we're studying these twigs, and people are actually taking, I guess that's good. I don't know. But it's indicated in Washington. So I think I'm not sure as far as how effective, but I know it's one of the indications that was approved through Washington. So that's the best I can say about it.
So if a patient gets authorized, then they can grow their own plant. Is the different plants have different THC, whatever level? How do they know if they didn't want to go out and buy it, how would they know what plant to get?
Yeah, and so that's a great question. That was part of it that I left out, is that they take their authorization form to a dispensary, and then there are consultants at the dispensary, and I think they take a 20-hour course. And so they are authorized to help guide patients as far as what like plants or what product to buy. They can't, and then they can help kind of say how to use it. And they're not offering any medical advice, but we are sending them to this place where they kind of are offering medical advice. And so, like, Charlotte's Web was a very popular line, and that was what was used for, her name was Charlotte. She was a little girl who had seizures and kind of fueled this whole CBD debate. And so my guess is that for that condition, they would kind of guide you towards a high CBD product. If that migraine study, they used something called OG Shark. I didn't look at the exact content of it, but that had a certain THC to CBD content. And the third part of it is that, as I mentioned, terpenes is another growing field. And so it's thought that depending on which terpenes are used, it's going to like affect the scent, but it's also going to potentially affect what effects are going to be experienced. So it's sort of like a three-part thing, because it almost doesn't make sense to look at it as just THC and CBD, and that just changing those ratios would cause the plethora of different effects that you experience from it. And so it seems like there has to be more. And so maybe it's terpenes, maybe it is just the ratio. We don't know yet. And it's hard to do studies when, I guess two things, when this is what we're studying. A lot of those cigarettes, I think the highest percent was 6%. I know 22% is not abnormal. And so I think it'll be hard to find a product because there's so many products. And so finding an exact prescription or an exact thing, I don't think is possible given the variety of different products that are available and their different concentrations.
So it's kind of classic for the state of Washington to legalize a drug and not know how to determine if you're a DUI when you use it. But if you adjust the THC level high enough, then Fox News starts sounding like CNN, and you have this illusion that Congress is actually getting along. So basically, that there's lots for us to learn, it sounds like. And Emily, thanks for coming.
Yeah,
and I think hopefully this is just something that'll prime the thought process in your head. And I can tell you that our anesthesiologists can tell me with 80% accuracy whether somebody is using marijuana when they induce them under anesthesia. They chew through narcotics. They really do act differently. And the other thing that I found that's very interesting is I always ask patients, do you smoke? No. Do you use any recreational drugs? No. Do you use marijuana? Oh, yeah, I smoke it. Well, I mean, you just told me you didn't smoke. Well, it's not a cigarette. You told me you didn't use any recreational drugs. No, it's legal. So my point is you have to frame it in a way where you say, do you use any marijuana products? And our anesthesiologists are very appreciative when we note that in our note. It's not a judgment. It's to give them a heads up to know that they might be up for a little bit of a more squirrely induction and wake up. So anyway, thank you very much.